And now I'd like to introduce today's speakers, Doctors Ken Boockvar and Amy Linsky. Dr. Boockvar is the director of the Division of Gerontology, Geriatrics, and Palliative Care at the University of Alabama at Birmingham. He also serves as a core investigator and leadership team member at the Birmingham Atlanta Geriatrics Research, Education, and Clinical Center. Dr. Boockvar has pioneered research on the quality of medication prescribing and the effects of interventions to improve prescribing practices. A leading researcher in long-term care quality, he has 25 years of experience treating older adults and individuals with serious illnesses, as well as advancing care for geriatric syndromes. Dr. Linsky is a clinician investigator at the Center for Health Optimization and Implementation Research, the New England Geriatrics Research, Education, and Clinical Center, and in the section of General Internal Medicine at the VA Boston Healthcare System. She is also an associate professor at the Boston University School of Medicine. Dr. Linsky's research interests focus on reducing low-value and potentially harmful care. She has spent most of her research career conducting studies related to deprescribing. Dr. Linsky uses a variety of research methods, including qualitative, survey, secondary database, and interventions to better understand how we can improve the safe and judicious use of healthcare resources. And now I'll turn it over to Doctors Boockvar and Linsky.
Thanks so much, Raha. Really happy to be here today, Ken and I, to speak on behalf of the VA Center for Medication Safety and Aging, specifically some research and implementation findings. We know this is going to be an audience that probably knows a fair amount of background. So just some disclosures, we are funded by the VA National Center for Patient Safety. I myself have received some speaking and writing fees for some deprescribing related work. So the VA Center for Medication Safety and Aging, for those who may not be familiar, first off, we're talking about the US Veterans Health Administration every time we say VA. But really, it's a multi-pronged effort. One is to advance the science of deprescribing, where we have sites across the country and really trying to support the development and testing of interventions, as well as to identify barriers and facilitators that can inform implementation of those interventions, right? Getting people to do the thing. And then finally, to try to disseminate prescribing interventions across the VA. Been in existence for 7, am I doing the math right? 8 years now. And are about to have just started funding for another 3 years. So the obligatory slides that have to be in any deprescribing related presentation. So we're going to frame this a little bit more around potentially inappropriate medications. Sometimes we do it more around polypharmacy, but really thinking about any medicine could be inappropriate and therefore ripe for deprescribing. The common risk factors that we think about: having multiple care providers, being in long-term care, transitions in care, and then the known negative consequences of inappropriate medications, including adverse drug events, falls, mortality, decreased quality of life. To define deprescribing, using the definition by Scott and colleagues, really focusing on the fact that it's proactive, it's systematic, it's part of the process of any medication management, and really thinking about discontinuing drugs when harms outweigh benefits, and it's individualized for a patient's goals, function, life expectancy, values, and preferences. But we're also very well aware that there's many barriers to deprescribing, whether they are at the level of the patient, clinician, family, the system. Many studies have been conducted that really show that there's a lot of barriers to deprescribing. On the flip side, though, we do know that there are some strategies to improve it. So first, I want to talk about one project. And as I mentioned, we had multiple projects going on at different sites across the country. This one is one that I led and was really focused on trying to understand and address patient-level barriers, specifically by engaging patients to promote deprescribing. So we used VA adapted Empower brochures. Many of you may be aware the Empower brochures were developed by the Canadian Deprescribing Group. And with their permission, we adapted several of them. We also developed one de novo, the one you're seeing on the screen right now, which was for gabapentin, but really modeled after the exact same template, and they were doing one at the same time, and there was a lot of overlap. But we really wanted to ensure that they were adapted for the VA. And so some of the differences, changing pictures, but also for gabapentin, we included a lot of non-pharmacologic modalities that are available within the VA, trying to think that to treat pain. So we had 3 medication-based cohorts, and they were basically designed to get at different medicines that might have different value of care, right? So proton pump inhibitors may not be so harmful, but are often used when not necessary, and therefore could be considered low value. And then we had 2 medication groups that were more at the high risk. So for the sulfonylurea insulin group, or the hypoglycemia risk group, we really wanted to address the risk of hypoglycemia in older adults who have really over-controlled diabetes. So their A1C had to be less than 7, and they were either age greater than 65 or had kidney insufficiency or cognitive impairment. And then the other high-risk group was high-dose gabapentin. Now, this one targeted patients taking a total daily dose of 1,800 milligrams a day, which above that, you don't really get much benefit in the medication in terms of pain management, but you are at much higher risk of adverse events. And we were also pretty liberal about excluding diagnoses where gabapentin could be recommended. We didn't limit it to just FDA approved indications, because as you may know, there's very few indications, FDA approved indications for gabapentin. So this study was designed as a pragmatic quasi-experimental. We really wanted it to flow with real world practice. So we had 3 geographically distinct VA sites, and our control group was basically the patients seen by study primary care providers, study PCPs, prior to the intervention. And we really wanted to understand or be able to control for the fact that some PCPs may be really into deprescribing, others not so much. The one thing that we were also wondering about is this was going to be an 18-month study, and that the longer you had patients, so like I had a patient coming in on month 1 with one of these brochures, I may respond differently than if I did in month 15. And so because we had these 3 different cohorts of medication-based patients getting the medication-based brochures, we ordered PCPs, randomized the order in which they got their patients were getting the brochure. So to put this in visual, so as you can see that there's a baseline period prior to the intervention, and then 6-month waves. And so if I was in this group, then my patients who are on PPIs and eligible for the intervention got the brochures. And then after 6 months, it would switch to only my patients who are at risk for hypoglycemia, and then the high dose gabapentin. A different PCP could be in a different ordering. We had 2 key primary outcomes. The first, because we're talking about deprescribing, was whether or not that medicine was dose reduced or stopped at the 6-month mark. But we're also really interested in engaging patients. Were we able to get them to bring that brochure in, have a conversation with their PCP, regardless of what happened to their medication? Primary predictor was the receipt of the intervention, and then we adjusted for patient and clinician characteristics. So the 2 parallel analyses, one was the deprescribing at 6 months, and then the second one was looking at deprescribing discussions. So what did we find? Well, the population was pretty reflective of the VA population. So average age was about 70, slightly older in the intervention group, but probably on a clinical level, not that relevant. Mostly men and mostly white. With respect to deprescribing, though, we found that the intervention cohort, 29.5% had deprescribing compared to 25.8% in the historical control groups. This was a statistically significant difference, but also it was a lot higher than we expected. And whether there were other factors going on, other initiatives going on, we anticipate yes. But we did see this difference between the intervention and the historical controls. So what was responsible or what was associated with it? So happily, from a research perspective, the brochure itself, if they got the brochure, they were more likely to have deprescribing. Also, regardless of brochure receipt, what we found was that the gabapentin group was more likely to have deprescribing than the reference PPI group or the diabetes hypoglycemia group. And our thinking there is that this is a very symptom-based medication, and clinicians are probably a little bit more interested in reducing the dose because of the harms at that high dose. We still are doing a little bit of work to try to understand what happened with that group, but we did see that this high dose group had more deprescribing. What about the discussions? So it was a subgroup because not everyone responded to the survey, because we sent the survey out after the primary care visit. About 43% responded. It was the respondents were pretty similar with regard to baseline demographics, mostly older white men. What I do want to point out is that the health literacy was pretty good. 89% had adequate health literacy, and that's going to be relevant for the future. So hold on to that thought. Most also reported engaging with the brochure, but again, this is a sample who responded to the survey. 29% read it, 33% also did at least one of the brochure activities, so something like that true-false quiz. And notably, more than half indicated that the brochure caused concern. And we consider this a good thing because the point of these brochures is really to break the inertia, the thinking that everything is okay. In terms of discussions, 29% reported they had a conversation with their PCP, and 78% of those indicated they were the ones that started that conversation. So we really were able to activate patients to become more engaged in their healthcare discussions. So what were some factors associated with discussions? Interestingly, and potentially on a little bit in contrast, what we found with the deprescribing was that the diabetes hypoglycemia group was less likely to report having a discussion. Our theory on that one is that these are medicines that when patients are started, when we think about like what we do as clinicians, you're like, you need to take this medicine every single day. It's very important. You'll probably take it for the rest of your life. And it may be a little bit more of a clinician-driven medication decision, so that they felt that they didn't really need to speak up about it. We also found that respondents who identified as Black were less likely to report a discussion than those who identified as white. Increasing levels of education were associated with discussions, as were increasing levels of brochure engagement, and perhaps on the most obvious of face value, if they on the survey indicated that having a discussion was important, they were also more likely to have had a discussion. So some key findings from this particular project was that the direct-to-patient brochures were able to effectively promote deprescribing and patient engagement and deprescribing discussions, showing that patient engagement can be a really powerful strategy to implement change in clinical practice. And it's a low-cost, low-tech intervention with potential for easy dissemination and spread. So great, we have one potential strategy to overcome some patient-level barriers. But as I mentioned, this was a population with relatively high health literacy. What do we do with patients who may not have that health literacy or may have some physical or cognitive difficulties with their medication management? So to that end, our colleagues at the Ann Arbor site, Kristen Phillips and Christine Segoli, wanted to really think about how to better assess the more comprehensive ability to manage medications. And so they implemented a project called the telepharmacy model of care. And this was really important because it addressed a more comprehensive assessment of medications, medication safety, and medication management. But it really also tried to improve access to care because getting to a physical site sometimes can be difficult. And so this intervention was delivered with a telemedicine modalities. And we also know that personnel can sometimes limit access, right? If we can't hire enough people to do the med rec, it takes time. And so they instead trained pharmacy technicians to be part of the interdisciplinary, interprofessional aspect of deprescribing that we're really trying to move toward. The intervention itself was 6 steps. The first 2 are the ones that we're more used to seeing with respect to deprescribing. So first was to assess the medication list accuracy and then its safety. And with respect to safety, they were really looking at deprescribing opportunities. And so medications could be labeled with red flags as high risk, as part of a problematic combination, or just it's a complicated regimen with different routes of administration and timing of doses, et cetera. But then steps 3, 4, and 5 were meant to assess the patient's cognitive ability, their health literacy, and their physical ability, right? Can they open up the pill bottles? Can they administer that metered dose inhaler? And then if there were deficits, in step 6, they assessed the presence and ability of a caregiver to compensate for them. So this was a population study sample of 121 veterans. Again, older age, more than half had a high school or higher educational level. About half, maybe a little bit more, were the intervention was delivered by video. The remainder was by telephone. And similar breakdown were delivered either by the PharmD and then by the pharmacy technician. So with respect to safety, what they found was on average, patients were taking 11 medications, and there were 2.6 discrepancies per patient. 41% of patients had at least 3 discrepancies. In terms of opportunities for deprescribing, 30% of those patients had at least 1 red flag medication, 71% had at least 1 high-risk medication, and in total, 68% had at least 1 deprescribing opportunity. Some had more than 1 per patient, so there was 142 medications that were flagged for potential deprescribing. Of those, 38 or 27% resulted in actual deprescribing by the clinicians. We talked about that comprehensive assessment, and this is where I think it really expands into parts of deprescribing that we haven't really focused on quite as much. So 20% of the patients had cognitive or health literacy difficulties, 41% had functional difficulties, but yet 66% did have a caregiver involved. So here we can see that this telepharmacy model of care can address barriers to self-management beyond just, is the medication safe for the patient based on their clinical profile. It also used telemedicine to improve access based on physical ability to get to an appointment. And it also incorporated pharmacy technicians, so really expanding the interprofessional, interdisciplinary approach, again, in the interest of improving access to care. I'm going to hand it over to Ken at this point.
Great, thanks, Amy. And thanks for the introductions. Really happy to be here and share additional work from the Center for Medication Safety and Aging, from the VA. And I'm going to continue with one additional project that we support, and as well as our dissemination efforts. You heard from Amy some patient-focused and patient-directed interventions, and we're going to show you some results from a more clinician-focused intervention that took place at the Durham VA, led by this group here, and also focusing on 2 goals. One is to show that deprescribing has an impact on veteran or patient health, so and by way of reducing the risk of falling, and also to start to look at ways to strategize to streamline interventions so that they're scalable. So by way of background, falls are harmful, costly, and medication use is a potentially modifiable risk factor. The intervention for this particular project was called FAME, or Falls Assessment of Medications in the Elderly. And again, the aim was to identify an effective approach, but also one in a number of iterations that was most scalable, most feasible for frontline teams to adopt nationally. So it consisted of, this intervention consisted of a screening step and then an intervention, 3 steps. The screening was focused on high-risk patients who are older than 65, who either had fallen or had a fall risk, a fall risk factor, and they were receiving at least 1 fall-related medication. I'll show you that list in a moment. And this is the full intervention, which consisted of an electronic consult or electronic case review, in which the chart was reviewed and a interdisciplinary team created recommendations after a discussion. So there was a team meeting. The team consisted of medical personnel, so physician trainees, a pharmacist, and the nurse. Then the second component was alerting the prescriber of the recommendations. They tried to keep their recommendations to 3 or fewer, and they did this through the VA electronic health record. They focused on patients' primary care and mental health providers because those were the most common prescribers of fall-related medications. And then the last part of the intervention was a nurse telephone call to the patient, going over the deprescribing recommendations and sharing with the patient that the patient's physician or prescriber was also part of the, had been involved in this plan. And that was done by telephone. So these were the target medication classes. You can see that most of them are neuropsychiatric medications. So again, targeted because they're associated with falling, but there are a couple of cardiovascular medications in there, alpha blockers, as well as diuretics. And you can see on the right, the flow of patient screening. And in the end, just in Durham and the Durham VA region, over almost 7,000 individuals who screened positive for age, risk for falling, and greater than 1 fall-related medication. So these are results that show how both providers or prescribers and patients reacted, or the acceptance of the deprescribing recommendations provided by this team. And you can tell by the relative length of the orange to the full bar that most of these recommendations were acceptable to both providers and patients. If you look along the x-axis, the x-axis has different categories of fall-related medication, from anticholinergics to alpha blockers. And then within each of those categories, there's a primary care prescriber, PCP, mental health prescriber, MH, and then the patient. With the notable finding that primary care providers were the most accepting, whereas mental health providers and patients were a little less accepting of recommendations. Their primary outcome was the drug burden index, which is a validated summative measure of cumulative risk, mostly related to anticholinergic properties. And in fact, at 1 year, intervention patients who received these components had a significantly decreased odds of a worse drug burden index, 63% lower than controls. So 0.37 is the ratio. And in addition, there was a trend for fewer fall-related encounters. And this is significant because many falls are not recorded because they don't present to healthcare systems. So the fact that they had fewer fall-related visits suggests that perhaps with a larger sample size, which I'll show you in a second, that there may be an impact on falling. So this project was designed from the beginning to identify ways to streamline what was actually a fairly complex and resource-intensive intervention. And I'll show you again how they did this, to identify ways to make it more scalable. And so the first thing, on the first reiteration of this project, they changed the target population and medication classes. As I showed earlier, there were almost 7,000 patients just in their catchment that fulfilled criteria for their broader criteria. When they reduced the target population, and this is the way they did it, they focused on neuropsychiatric medication classes, so they eliminated the diuretic and alpha blockers. They also changed the number of fall-related medications to 3 or more from 1 or more. Again, in order to identify the patients that were highest risk and potentially most likely to benefit, and reduce their target population. They also changed the components that they delivered. So they actually developed a stepwise sequencing of strategies that they then compared in a fairly rapid cycle, intervention cycle. So I mentioned earlier that strategy 1 consisted of electronic consult with a team meeting. That's represented by the people in this this figure, then communication with the prescriber, that's represented by the envelope, and then talking with the patient on the phone, represented by the telephone. In strategy 2, they eliminated the telephone call with the patient and included just the team meeting and the recommendations communicated with the physician, with the message that the physician would, or and the hope that the physician would have this conversation directly with the patient without them needing to do this, with the same impact potentially on deprescribing. The third strategy reduced the components and complexity even further by eliminating the team meeting. And I think this was partly because with time, the folks on the team became expert at identifying and making recommendations such that there was no need to really discuss every single case. And so in the strategy 3, there was a chart review, and that consultant was able to make recommendations on their own directly to the prescriber. And the outcome was, again, drug burden index of 1 year, comparing these 3 strategies with sequentially less, more streamlined. And the results, first, the patient population. I think the main thing that I'd like to show here were what medications were most commonly being received. And if you look not at the red boxes, but just above or between the red boxes, you could see that the most common target medications were anticholinergics at well over 80% in each group, and antidepressants at over 90% in each group. The red boxes just show some of the differences between the study groups, and these differences are explained by the fact that this was not random assignment. These were sequential cohorts, and so they needed to account for these in their analyses. So there are some differences in cognitive impairment and receipt of some other classes of medicines. But you can see at the top there were 4 strategies in a control group. I'm sorry, 3 strategies in a control group, each with about somewhere between 85 and 129 patients. So here are their results. Again, the primary outcome was drug burden index. And you can see here that these negative numbers mean that an improvement, because drug burden is higher the drug burden, the worse. So negative numbers are improvements. You can see across all 4 groups improvements. And in fact, not necessarily the expected dose response among the strategies. So you could see, at least this first slide, that strategies 3 and 2, which are streamlined, they don't have all the components, have a negative, an effect, as well as strategy 1. And we're seeing some, trend in the controls as well. But when you control for differences between these groups, between the baseline characteristic differences, we do see that intervention strategies were better than control. And the improvement is expressed here as odds of worsening drug burden index compared to controls, for which a ratio less than 1 is a benefit. So you can see in each of these strategies, the ratio is much less than 1. And so you could say that somewhere between 60 and 70% benefit across all 3 strategies, but interestingly, no difference between the 3 strategies, even though strategy 2 and 3 had fewer components. In fact, the component that was left at the end was just electronic consult with recommendations to the provider. And we can talk about that, the implications of that in the discussion. So our project at the Durham VA showed that Deprescribing conferred lower odds of worsening drug burden index at 1 year. Of interest is that they found that this impact appeared to be on preventing additional fall or risky medications or risky prescriptions rather than deprescribing existing use. So that's something that is in and of itself is interesting, but also that lower intensity, lower resource strategies that are potentially more scalable, whereas as effective as the higher intensity ones. So this was all relevant to what we also are charged to do by our sponsor, which is to spread deprescribing across the VA. Now, our sponsor, which is the Center for Patient Safety, is, so the way that it spreads there's a whole network of patient safety officers in the VA, and there's more to this than you probably would want to know, but they also support, innovative ways of spreading interventions. And so this is a intervention, this Breakthrough Series Collaborative, which is not meant to actually touch every single veteran across the system, but develop a way that we might be able to impact more veterans, especially early adopters of deprescribing. So this is not meant to, again, touch every veteran. So what is a breakthrough series? Many of you are familiar with this. The term, I think, originated with the Institute for Healthcare Improvement, so IHI. And it's basically an approach to select teams that are ready for change, ready for improving, quality improvement, and also provide them with support and mentoring to get, to a stated goal. So how do we, actually implement that? How do we select teams? Well, the methods include a assessment of the team, looking at whether a frontline team is, has the evidence that they're ready to make change, that they're capable of making change, that they have adequate and broad champions, that it's not just, one person who is unsupported, then they have broad support and commitment from, from the organization and potentially their supervisor. So we need to make sure of that, because, working with teams that are not ready or not well, not equipped, is a setup for not doing well. And then what do we provide after our, selection process? We provide, and I think the most impactful thing is one-to-one and small group mentoring and facilitation meetings with the teams, as well as shared learning. So teams, as they move along this pathway of improving or changing their practice, share their experiences and their, their challenges and successes. We also provide a mechanism for them to measure. Many frontline teams, as you know, in healthcare, do not always know how they're doing. This is one of the things. How do you know that you're improving if you don't measure it? So we provide audit and feedback with recommended standard measures. And we also, because we're a part of a center of excellence, or we are a center of excellence, and we have thought leaders, we involve our project leads. I mentioned the Durham VA, the leads from Ann Arbor and Boston and others. And so when we have an alignment, let's say of a frontline team, an interest of a frontline team that aligns with one of our experts, we are able to provide, additional technical support. And so I think these are all reasons for our success. We also have opportunities for frontline teams to talk to veteran experts or patient experts through a veteran and caregiver council. We also provide information on deprescribing tools that were developed and are actually customized for the VA. So, we heard about direct-to-patient Empower brochures. That's the second line here, deprescribing materials. But there is a nationwide rubric for folks and dashboard for folks interested in implementing deprescribing called VION, which is a rubric, stands for vital, important, optional, not indicated. It's a way to prioritize or select medications for deprescribing, with targets being those that are not indicated or optional. That's available across the VA. We already mentioned the deprescribing. I mentioned direct-to-patient materials. Deprescribing e-consult is something developed again at Durham, and then we have a few others. And so, providing these to VA teams, of these interventions that were developed in VA, is appealing, and they're available through our sponsors SharePoint. So we followed, again, the VA being, really a national leader in, quality improvement. We followed you could say, a recipe provided in this article by our sponsor. So these authors are from the National Center for Patient Safety, and we adopted a virtual modality. So the original Breakthrough Series collaboratives were done with a lot of in-person meetings, and this was adapted to be virtual. And in fact, if you look at this is just this is one of our collaborative groups, and you can see it's truly nationwide in multiple time zones. So we are currently in our third Deprescribing collaborative. We're just launching it this year. We've had 2 prior ones, and I'm going to show you some results from 2 prior cycles of Deprescribing virtual Breakthrough Series collaboratives. Oh, and this is a typical timeline running from 9 to 12 months with initial engagement, a kickoff planning phase with frontline teams. Often these are led by pharmacists who are enthusiastic and about deprescribing and medication safety in general, with support often from medical directors and medical services. Anyway, so planning phase, meeting the teams, helping them through a planning to get them to launch over a course of 2 months or so, to launch their deprescribing intervention, and then a high touch action phase where they're reporting back their results, reporting back challenges and successes, and we're providing support to try to help them work through those challenges. And I'll show you some of those. And then easing off, basically weaning them off our support over towards the end of this collaborative. So this is just some of the results from our first 2 groups. You could see here that the practice settings where deprescribing interventions in the VA were implemented are fairly broad, including ambulatory care, home-based care, nursing homes, and then we had some interesting other specialties, not so much in inpatient settings, hospital inpatient settings. We did have 1 emergency medicine group, although they were not so successful. Partly because it was hard for them to attend our meetings. And then you can see here the intervention methods, often using the VA-supported Vione dashboard and tools, but also some other methods as well. And then to give you a sense of what our penetration was across numbers of patients and how many medications per patient and per time period. This is a little bit of a busy slide, but I would just point to a few things here that on average, each team would engage with 1 patient per day, which resulted in 1 or 2 patients per day with their intervention. These are teams that are doing regular clinical activities as well, and they were trying to incorporate this often into their regular workday. So they would engage with veterans 1 to 2 per day, and each veteran, they would be successful in reducing by 1 to a little bit less than 1.5 medications on average. So you could see a pathway potentially to getting deprescribing really incorporated into regular practice. This is compared to the size of the VA, this is a relatively small group, but compared to other deprescribing efforts, this is a, relatively large group. And again, these are folks that are going from 0. So you could see that, this is an impact. We don't have a concurrent control group. I apologize to show you, but partly that's because this is a, a collaborative and not a controlled study. So again, about 1 to 2 patients per day, per month, per team, and 1 medicine per patient deprescribed. Some of the barriers that they reported back, staff turnover, difficulty maintaining momentum over time, both in the VA and outside the VA. When medicines are prescribed by people you don't know or outside your system or your setting, it's hard to know how to intervene or how to make that happen if you're trying to reduce medicines. Of course, our patients sometimes have symptom relapse and they go back on their medicines. Even in the VA, which is a nonprofit and actually where most of the providers are at arm's length from finances, so some teams needed to show cost-related benefits to maintain facility support. And then, of course, data collection remains a challenge for frontline teams that, again, this was not required. So, making sure that data collection is as seamless as possible. There were some unanticipated benefits as well, I think in the right, of course, in the right direction. So it seemed like once deprescribing interventions were implemented and were seen to be successful, there were other people kind of joined the bandwagon. So support from providers that were initially uninterested, adoption of deprescribing outside the initial setting, and then some evidence of changes in prescribing patterns and that deprescribing was being integrated into daily tasks. So, these are all, I think our goal, in this group and, is to really make deprescribing part of culture. And I think, this is part of the way to do that. The other thing to mention is, we have at least one project that was focused on telepharmacy. One of our cohorts overlapped with COVID, and all the teams had to move to a telepharmacy, modalities because of the, shutdown on in-person visits. So, and it seemed to be, there were some advantages to that, in fact. So in summary, and, we'll move to, Q&A. I think what's nice about the work that we're doing in the VA is partly just the fact that it's the VA, it's a national healthcare system. And, we can do stuff that folks who are not part of a national system can. I think the other thing is having the sponsor and the sponsor willing to support at the same time research exemplified by, Amy's project and others at the same time in the same, sort of under the same umbrella as dissemination, and allowing that, really those two activities to enrich themselves. So I'll stop there and see if there are any questions, discussion.
Thank you, Drs. Linsky and Boockvar, for your excellent presentation. I'd like to invite our audience members to please enter your questions using the Q&A feature at the bottom of the toolbar. To get us started, what are some of the next steps or new project ideas that you're looking to pursue off of this work?
Amy, do you want to take?
Yeah, I'll tell you. So,
Okay.
so actually all 3 of the projects, the 2 I presented and the one that Ken presented, are all moving forward in this next iteration of our center. So for mine, we're actually only at this point focusing on the hypoglycemia risk, really trying to think about the safety aspects of deprescribing but expanding, there's a core group of folks who are very interested in deprescribing. Typically, we think about pharmacists, think about geriatricians, maybe primary care. But we haven't moved, with the exception there's, some folks doing work in other specialty areas, but mostly this has been like a primary care geriatrics focus. And so we're interested in this hypoglycemia risk, thinking about subspecialists and specifically endocrinologists. And how does that interplay in the co-management of patients? Think about ownership of medicines, both from the clinician perspective as well as from the patient perspective. The telepharmacy model of care is continuing onward, really thinking about how to continue to expand access and do comprehensive assessments. And the falls related study is actually adding is continuing as well, but they're also integrating we're trying to explore the role, and you guys will be hearing about this, I think in 2 weeks, 3 weeks, 4 weeks, sometime from Dr. Pavon, the role of AI in deprescribing and some potential opportunities there. And then the others, we're also expanding another project site to think again about subspecialty care and thinking within the rheumatology space. Really trying to tap into some of those specialists that may or may not have had as much exposure to deprescribing, because as Ken showed, maybe you didn't know about it early on, but as people start learning more, we're getting a little bit more traction.
Awesome. Our next question we have is, when these interventions may disseminate to other VAs or sites in the VA, beyond where those interventions were tested, how will you monitor this as becoming like an ongoing part of routine practice?
See if Ken's got an answer.
Yeah, I mean, I think that's so one of the challenges, and I think that's something that USDEN has done some work on, is how do you identify deprescribing in data warehouses, and I know that was one of the research objectives of the USDEN. I think the same question, without having a sort of discontinuation order, and with many medicines just hanging around, it's hard to know for sure that a deprescribing event has occurred. But we look forward to that's an inadequate response. But Amy, do you have any?
Well, so I think the others, with respect to some of the interventions themselves, so the Empower brochures, there is another group that is also working on this within the VA, and have been able to post, or basically we have a diffusion and innovation marketplace, and so they are available. So I don't know that it is how trackable it is to find out who downloaded those brochures and whether they were being used in other facilities. At that point, it's kind of gone beyond the scope and is now a tool that can be used by anyone. So that part isn't as trackable. I know a little bit less about whether the telepharmacy model of care or whether FAME has been made more publicly available, or at least publicly within the VA.
Great. We have another audience question. There was one of your slides that said deprescribing clinic, and I think we would love to hear more. What does that look like to you guys?
Yeah. So that's a little bit of a one-off, I would say. It's so at West Haven, affiliated with Yale. The deprescribing clinic is, with an acronym of IMPROVE, and I think you can look it up. I could even try to find the link. It consists of a visit really focused on deprescribing for a patient. And the visit consists of an education session. So patients, and it's a group visit or a group education session, then followed by one-to-one sit downs with a pharmacist. So it's essentially basically a pharmacy visit, but it includes some education component.
And I think also that, to kind of going back to this deprescribing, like there's been, in Boston 10 plus years ago, there was an initiative called the Pill Clinic, Polypharmacy in Later Life. But one of the issues, as Ken noted with the virtual breakthrough series, is the idea of sustainability, right? Like we're starting to talk, there's the intervention development, and then there's the implementation of the interventions. And we haven't gotten to the sustainability or the maintenance phase really just yet. And I think that that's going to be, clearly a next step, because it's great when we have all this, energy and something shiny and new, and it's like, let's try this out. And then people can potentially lose interest if it just doesn't become incorporated into regular practice.
Audience, please, if you have more questions, please do enter them in the Q&A or the chat. Another question that's come to us in the breakthrough collaborative, how much change in initial prescribing do you see versus deprescribing?
Yeah, that's a great question. I don't have it. I don't know the answer to that at that scale, because we asked in our standard measures really for them to track deprescribing, and again, it's a balance. I think it's a great question. It's a balance of what is feasible for them to do. And these are frontline teams again. I think measuring initial prescribing would require, sort of tracking whole medication regimens, whereas measuring deprescribing, just requires, paying attention to the sort of the recommended change and then seeing if it happens. So I think there's a little bit added data collection. We haven't asked them to do that. But I think it's, there might be some sites that would be willing to do that. Yeah. I did send you a link, Jonathan, to the Improve VA, and one part of that deprescribing clinic, which was asked about, is that it included trainees. So I think it was like, sort of a lab clinic where you had, the patient service, but also it was a way to teach the, trainees and learners about deprescribing. And I think that's a way that we can advance the field is by including deprescribing as a, regular topic of conversation in our, when we're precepting, patients as preceptors, but also, giving lectures and things like that. So again, bringing generally in medical training, it's all about prescribing. Like, what's the right medicine? How do I dose it and bring it? And I feel like we don't do anything really to teach folks when to scale back the medicine, bring it down or eliminate it. And so that's part of what this clinic does.
Well, I don't see any other questions coming in. So I have one more question. A lot of people are thinking about how to design new trials and have a lot to learn from the VA. Didn't know what opportunities you could speak to of like, what's it like to work with any community partners as you design these trials at the VA, like any stakeholders that you include in designing these, or how to scale, if you could speak a little bit to that for our audience.
Right.
So I can try taking a first pass at this. There's definitely a big push towards partnership with maybe a little bit community partners, but within the VA, there's central offices that there's one for geriatrics, there's one for pharmacy benefits and management. We're funded by the National Center for Patient Safety, and really thinking about, if you develop or show that an intervention is successful, who is going to own that? Who is going to take responsibility for making sure that that gets continued on, even when it is no longer a research funded project? So there's a large part of, whether it's grant funding or not, not technically grant funding, but quality improvement or evaluations of different types of efforts, really ensuring that there is a partnership with basically what are called operational partners that can take that on subsequently and make it part of their routine practices.
Well, I'd like to thank everyone for attending today. Our next webinar will be on March 4th, featuring Dr. Juliessa Bavan, who you got to see cited today in today's webinar. And she'll be talking about personalizing medication deprescribing and leveraging AI. So an exciting talk to attend. Today's recording will be posted on the US Deprescribing Research Network's website in the next few days. Please complete the after webinar survey that will be sent to you. And thank you again, and hope you all have a great rest of your day.
Thank you.
Thanks so much for having us.
Bye.